Well, good afternoon, everybody, and thank you for joining us. You've landed at the CAF COVID Weekly Roundup. My name's Jason Belden. I'm the Director of Emergency Preparedness for CAF, and I'm not sure if Patty's going to be able to join us today, but the topics for today are going to be the variants. We'll talk about the California Health Alert that was sent out last night and how that applies to us and what's applicable and what's more for health departments and things like that. So we'll cover that in depth so you guys know what to look for. We're going to cover the MMWR that came out this week that talked about second or folks that have caught coronavirus 2 times in skilled nursing facilities. So we'll explore that a little bit. We'll kind of reinforce what the current requirements on visitors and testing is, and then we'll introduce a fit testing video that's going to be free for you guys to be able to use now. Today is February 26th. I think that's correct, yeah, and it's 1 o'clock in the afternoon. As a reminder, CAF has a coronavirus website dedicated to resources that we've uncovered for the coronavirus. You're always welcome to peruse that. It gets changed fairly frequently. All right, let's jump to our traditional introduction. The speaker's opinions expressed are their own and may not reflect CAF's official position. These webinars are brought to you through a grant-funded program through the Los Angeles County Health Services Agency and the California Department of Public Health. I have no financial conflicts, and I'll be the only speaker on this webinar today. The intent of the webinars is to give you a situation report on things that have changed during the last week for the COVID response, some forecasting and best practices where we can identify those. And in the coming weeks, we'll talk about this towards the end, but we've got a really robust schedule over the next 3 weeks of speakers and topics that are going to be very much focused on best practices, as well as some other after action reporting and stuff like that. So, all right, let's hop to the first topic here, and that's to talk about the California Health Alert that was sent out yesterday. If you guys take a look at the handouts, in the handouts today is this the health alert that came from CDPH last night. Los Angeles also sent it out separately to their facilities this morning. I saw the announcement this morning. And the health alert goes in to talk about 3 specific variants of concern, and that's how they're terming these. So you may hear that that phrase, variants of concern or variants of interest. Those are all, you know, similar kind of terminology that's being used now. Let's talk about the first variant. And I know folks, it's easier to really use the common terminology rather than the numeric terminology. So I'll refer these to the actual plain language terminology, and then you can see in the paragraphs just what it relates to the actual variant and its numerical value. In terms of the UK variant, we've heard a lot about this. It spreads more easily. We know that it spreads a little more easily. The vaccine has been shown to be effective for this UK variant. What's unknown is whether it has a higher mortality rate based on that variant. They don't have enough evidence to suggest or to give a definitive answer on that, but it is definitely something of concern. The South African variant is similar to the UK variant in that it spreads more easily and quickly than others, and there's been preliminary evidence to suggest that the Moderna vaccine may be less effective against this variant, but additional studies are needed. In terms of the Brazilian or South American variant, the P1 variant, that has not been sequenced here in California as of yet. The variant does spread more easily and quickly than others, and there's evidence to suggest that some of the mutations in that variant may affect the ability of antibodies to be effective against it, both from natural infection and vaccination. But obviously additional studies are needed. The reason why I wanted to bring this up is not necessarily, we've heard a lot in the news about those top 3 variants, but it's important to note that there are variants of interest right here within our state that are also being monitored. And CDPH is calling these the West Coast variants. There's a number of numbers that are associated with it. So the B1429, B1427, and the Cal 2.0C. These may be rolled into one in that Cal 2.0C. I'm not certain how they're going to come up with the final nomenclature for this, but it is a variant that's detected here within California. There's been 2 specific studies done on this variant, one at UCSF and the other one at Cedars-Sinai. There's a great New York Times article from the author of that study, and we expect there to be the results of these studies to be published in MedRx, which is a medical publishing website that publishes research papers and studies before, basically before they become finalized. So we'll be able to get a look at some of the information. What we have noticed is that there's definitely what seems to be it's more infectious. And one of the study authors had suggested that this is most likely to become the dominant strain in California. We don't know yet as to the effectiveness of the vaccine on this particular variant. And I know folks go, well, okay, that's all. It's all concern. What do I do with this information, and how do I gather that information? And I think that's maybe the more important point for us in terms of operationalizing. How do we take advantage of this information? What should we be doing to help fill in the gaps for the public health departments? So the actions and when we need to take those actions are going to be during our screening or response testing. That's probably obvious that these are where we're going to learn of these positive cases. So during screening testing or response testing, if a resident or staff tests positive and they are 2 weeks post their second dose of vaccine, or post 90-day, or I'm sorry, within post 90-day recovery from COVID, meaning they have had COVID and they're post 90-day, you get a positive case in either one of those scenarios. What you'd want to do is ask the 2 travel and exposure questions listed in the KHAN. So obviously that is less of a reality for residents, but definitely for staff. We've heard cases of folks, traveling, and they go, do we need to get this information from them and things like that. So in the case where you have somebody that's post vaccine or post recovery testing positive, now if for some reason you tested somebody within that 90-day window, and they had recovered from COVID and now are testing positive again, I think that would be another kind of scenario where you'd want to take a look at it. Now, so we ask the travel and exposure questions. Have you traveled outside the country, and where to? Or have you been exposed to somebody that's been traveled outside the country, and where to? If you have one of those cases, now it's unlikely that you're doing your own PCR testing. So it's more likely that you're going to get notification from your lab that you have a positive COVID test. What you would want to do in those cases where they meet this underlying requirement, you're going to let your local health department know that this is a possible reinfection or breakthrough infection, as well as the history of the positive case. That's going to give the health department the kind of ammo they need to be able to investigate this, to see if it rises to the level of sequencing. The local health departments will facilitate that sequencing with the state lab if they think it may be a reinfection or a breakthrough infection. And now they may not have capacity to do everybody. And we certainly know that the time it takes from when they choose to do the sequencing till we actually get the results is sometimes 2 weeks, sometimes 30 days. It takes a while to get through that process. So you won't be able to make decisions based on the results of those sequencing tests, because you'll be out of whatever quarantine or isolation requirements there are for the positive test before you get any sequencing back. And I don't think that's going to change. I just think there's a supply issue or a throughput issue to be able to get enough of these sequencing tests done. I know the state has said they're trying to scale up those efforts, but as of yet, it's still very limited in terms of how many they can do. And they're sequencing about 2% of all the positive tests now. If you do your own PCR test, meaning you're maybe a DP SNF that has their own equipment, you can submit to the state lab directly if you have a contract set up with them. So if you're doing your own PCR test and you want to submit those samples directly to the state lab, you can do that. You just have the contract set up with the state lab to process those requests. If you do, forget, plane flew right over my head. If you do your own sequencing, you want to let your lab, your local health department, know the results of those tests. And then and it went on, and this is the important point to note, that the very last bullet point here. Any cases due to a variant of concern do not need an extended isolation period, but they should be monitored for isolation adherence. So that's great. There's all these other variants out there, or it's terrible, or however you look at it. The reality is, if you get a positive case, you're not going to know what variant these folks have until well after they've gone through their isolation period. So we're going to make sure that, I would say, in the cases where you think it is a breakthrough or a reinfection, we definitely want to follow those isolation precautions to the letter. And unless it's a really, really severe staffing crunch, and you could put that person in, that staff member in the red zone exclusively, if you had one, then maybe you might be able to work around that. But because of this possibility that these new variants could affect vaccine performance, we want to isolate those folks that could be possibly reinfected or with a breakthrough infection, and keep consistent with those isolation precautions when we can. All right, so that gives us kind of what to do with that. There's not a whole lot you can do. Most of the KHAN alert is instructions for health departments in terms of the actions that they should be taking. There's not a lot you can do in terms of isolating these folks before you learn that information. So don't think that you have to accomplish the sequencing, while you're, in your response, because I just don't think you'll get the results back to make any informed decision about whether this is a variant of interest or not. So I wanted to cover that, and then I wanted to talk about the Morbidity and Mortality Weekly Report that came out this week. And this really emphasizes the need to do sequencing on our population. There was a suspected recurrent infection among residents of a skilled nursing facility during a second COVID-19 outbreak. And the link to the report is obviously there on the bottom. These folks were not persistently positive. And I know we have tons of cases of persistent positivity well past 90 days. In this particular case, these were folks that were symptomatic, resolved their symptoms, tested negative multiple times in the interim during response testing, and then 3 months later developed COVID again. This time it came with more severe symptoms and mortality. So it would lead us to believe that these are recurrent infections rather than persistent positivity, because they came with much more severe symptoms and mortality. Once again, this just highlights that it is possible to get reinfected with COVID, and for our folks, it can mean very drastic health outcomes. So we want to continue our ability to isolate and contain as much as we possibly can until we get a better handle on the performance of the vaccine and the performance of the vaccine with the variants that are spreading in California. So the those two West Coast variants represent a pretty high percentage of the currently sequenced tests, and so it's definitely here, and we want to be careful and cautious before we rush to remove some of these infection prevention and control requirements. All right, I just want to touch on for a second the visitation guidance and the testing kind of frequency, and point folks back to where this information lies. The visiting guidance will change very soon, may even change this afternoon. I don't know. I've not seen like a final revision of an AFL, but I do know that we've been in communication with them about what this can look like for vaccinated folks and things like that. So I do anticipate that AFL coming out very soon, but for now, we're going to continue to follow the requirements that were laid out in 2022.5. As it relates to outside visitation, is kind of anybody is allowed to do that. But for those inside in-room visits, the group activities, the communal activities, all those are tied to the county color. And people frequently ask what website they can go to download that data. And I just, click on the COVID-19 Safer Economy website, hover over your county, you'll be able to see the county color. Now we know purple does not allow inside in-room visits, but for all of the other tiered categories, and all indications lead us to believe that most, if not all, the counties are moving in that direction. So it's great news. That will happen fairly soon. If you've not dropped out of the purple tier, you'll probably get there fairly soon. In terms of the testing frequency, which is a little more, kind of nebulous, what CMS has said is there should be a 2-week look back of data for you to be able to adjust that frequency to test, whether it's twice a week or once a week. And it's going to be one of those two criteria. Now, every Tuesday, that same website is updated with that information. So every Tuesday, you'll see a new numerical value given to that test, the county test positivity rate. Most of them are under 10% now, but if you've not been capturing that data and putting it into your mitigation plan, I think most of you guys have a date set in there, or you put a date in there at the beginning when you submitted your mitigation plan. So whatever date that you had identified in your mitigation plan, that's when you should be checking in and adjusting it. Now, if you didn't put a date into your mitigation plan, obviously go back in and say, we'll check it every Tuesday when the state website data is updated, and adjust accordingly. If you haven't been documenting the data, because the data only shows this week, it doesn't show what previous weeks were, but your local health department are the ones that submit that data to the state. So it's possible you may be able to get that information from them. They may be able to tell you what it was the week before and the week before that. If that's the case and you have data that they've confirmed that, for 2 weeks you've been under the 10%, then I would capture, document that source of information, whether it's an email or a conversation you have with your health department. Just document that, add it into your mitigation plan, put the dates that you're going to check in and on an ongoing basis, just so long as the surveyor, when they come in, that shows that you checked and you verified the data. I would go ahead and give those folks a call if you're not already tracking that. I think most of you guys are pretty close to being into the once a week testing if you're not already. So definitely reach out to your health departments if you're still testing it twice a week to double check to make sure that that's necessary. Because the surge really, really looks great in our facilities across the state right now. All right. I'm going to hop to next week's AFLs. We do anticipate one on staffing as well as visitor guidance for those that have been vaccinated. It's possible that may come out today, which throws everything I just said about visiting tied to county color, maybe. In any case, those AFLs will probably come out this week. And then next week, as we kind of, we'll cover those AFLs in depth, especially if they change your operation significantly. We'll dive into the nuts and bolts of it. But I've been trying to get a number of people as guest speakers to come on in the coming weeks to focus more on some of the nuanced questions that you guys have had throughout the response and continue to have, frankly, across the sector. So I'm going to have a gentleman who recorded a training video for us on our webinar, and he's great at respiratory protection, but that's not the only thing that he and his company do. So CAF hired this contractor to record a train the trainer respiratory protection video. It's set up in modules for your staff. This is really a guide for those that are new to respiratory protection, so it'll cover the basics, but it also has a complete instructions for qualitative fit testing. So if you buy your own fit testing hood, you don't have to do anything else. You can use this video as your competency to develop the ability to do the fit testing. I've said it's not particularly difficult, and it's not, and once you get trained on it and you get used to doing it, it's not that hard. But for those that are new in this position, or they've come from another department, care staff or something, and you've turned them into an infection preventionist, if they have questions about respiratory protection, or they're at the beginning of their career in infection prevention, it would be a great full hour-long training for those folks. This is freely available. Anybody can watch this. These tips and training tools apply pretty broadly, not just for skilled nursing facilities, but the video is done specifically for skilled nursing facilities. So I will say the qualitative fit testing process can be used by anyone. So if you're an ICF on this call, you can use that fit testing video as your training to be a qualified fit tester. Gosh, and in terms of what we're going to discuss, bring your questions about PPE, but really bring your questions on disinfectants and airflow and things like that. We'll have that gentleman on for the entire time, and he's great at answering questions. So we'll have a full program, and I've been keeping track of questions that folks have, kind of traditionally been asking about each one of these things, and we'll pose those questions to this gentleman. He's fantastic. His name's Derek Dene. Like I said, go ahead and feel free to click on that video and watch it, and have your staff watch it as well. So that was all the updates we had this week. We really anticipated a huge AFL to drop this week, and it did not, and so we'll pivot and we'll do that next week. I'm going to hop to questions, and maybe we'll get out of here before we even get to 12 or 1:30. We'll see here. All right, so the first question, I forgot to say, guys, if you have questions, please feel free to drop in the questions in the question and answer box, and I'll get to them as quickly as I can. Can you revisit your recommendation on extended use of eye protection, eye shields and goggles? I missed your presentation yesterday. Yeah, so this is, if you guys listen to those calls on Wednesday or Thursday, you'll notice there's a lot of questions about the use of eye protection. And at the beginning of the response, or during the somewhere in the middle of the response, and frankly I can't remember when it changed, but there was a big recommendation from CDC and CDPH to extend the use of eye protection across the space, meaning just like source control, wear eye protection. Now, I missed where that kind of recommendation was changed, but I clearly heard Vicki and Vicki Keller and Dr. Aaron Epson say that it's not required as long as it's you're not within that 6-foot bubble of an exposed or a COVID positive resident. So what I'll say is that if you use eye protection, if the eye protection you have is designed for repeated use, it's not designed to be disposable. It's designed for repeated use. And what you'll do is you'll look at the product information sheet. If what you get, I mean, it should be a no-brainer, really. The reason why there's another, the CDC added this to a conventional strategy, whereas eye protection wasn't considered a conventional strategy to reuse that, but now the reuse of those devices is allowed, and the argument is, full face elastomeric respirators, PAPRs, those are permanent equipment that offer eye protection as well as respiratory protection. Those devices are meant to be used and cleaned after each use. Same thing with goggles or face shields. If the design of the goggle or face shield is designed to be reused, then it's okay for you to continue to use that. You just want to make sure you clean and disinfect after each use. That's really all I said from the presentation yesterday. It's good news that you don't have to now wear your eye protection 24/7 while you're in the building, but I would me personally, I would do a lot more than what the minimum recommendations were, and if I had the ability to keep eye protection on. I realize it's cumbersome and weighs on your, especially if you got one of the shields, the kind of weight of it, weighs on you after 8-hour shift doing that. There is an allowance for you to reuse eye protection, but that must be a part of its design. Our news, okay, and that's next question. Any news about the state resuming recertification surveys? Yeah, I think it's closer than we may think. They haven't given us a firm date, but there's been definitely talks of resuming recertification surveys. We've seen like a Title 22 survey, we've seen federal surveys, but we've not seen the normal surveys resume just yet. They are in other states, I'll tell you that, and I think it will be fairly soon, maybe within the next couple of months, we'll see resuming recertification surveys. Do you have any data on how many percentage of residents and healthcare workers in SNF got vaccinated? That's great information. It's information we're trying to gather from disparate sources. We've asked, CDPH does a questionnaire on their daily survey, and they ask questions about vaccine coverage through the facility. And we were trying to gather that data from CDPH. And my hope is they'll be able to get it to us. NHSN gathers some data, but because not everybody has conferred, or most people conferred their rights over to CDPH, not everybody's reporting to NHSN, so we can't really gather the data from NHSN. It would only be a really small view of it. So I think, our national association, the American Healthcare Association, really wants to push to get a minimum of 75% coverage in both residents and staff. And I'll say that us as a state, on the original information that we received from Walgreens and CVS, was that we were tracking well below that in terms of percentages of staff but we were closer to that in percentages of residents. And I will say that was really early on, and we haven't had good data in the last month. I fully expect that to be much better than the original data that we got, but until we get that information from public health, I would be guessing in the dark, and it would be, I could be plus or minus 10% on my guess. All right, is COVID vaccination reporting on NHSN optional or required? And that's a good question, Rod. I think it's, if you're reporting to NHSN and you've not conferred your rights over to CDPH, whatever questions are on their survey are required for you to fill out. I'll double check that for the person that asked that question and see if I can post a response to the forum. And Summer, can you do me a favor? If you see that question, can you make sure you highlight it on the notes so I can follow up afterwards?
Of course.
Yeah, thanks. All right, next question. The vaccine companies talking about to have third dose of vaccine for the variants in the news. Do you have more information on that? I don't, but I do know that both Pfizer and Moderna are working on booster shots, but they're trying to take information in real time from the variants and develop those booster shots. So I think it will come. If necessary, it will come, but it won't be for a while. I think what's more likely is we're going to see this third vaccine get approved tomorrow, probably from the FDA. The FDA is reviewing the Johnson & Johnson stuff. And we believe that they're probably going to approve it tomorrow. That usually means there's a couple week lag time before we start seeing that being operationalized throughout the country. All right, looks like AFL 20-32.1 suspension of regulatory will expire on 3/1. Any update on the extension, or is it over? No, I believe that is set to expire on 3/1/21. I don't believe, maybe some of those will get revisited, but not all of it will. I don't think. It may be possible that the entire thing goes away on 3/1. But we'll keep you up to date on that as well. Any thoughts about having Jennifer or Jeff come back? Yes, I would love to discuss payback of funds we've received. And that's a great thing. I'll ask Jeff or Jennifer to come back on to discuss that. I do know in terms of our recovery plan and what we're doing around recovery for the providers is we've got an educational series that we're in the process of developing. And CAF has a number of work groups. I have a number of work groups, and I'm going to utilize the folks on my work group to kind of give us, kind of programmatic direction on where those educational things should be. And this is definitely top of the list. There's going to be after action reporting. We'll talk about that. I'll do that on this webinar for sure. I'm going to cover a really basic after action at the end of this month or at the end of March. And what I'm going to take folks through in terms of the after action is just to get you through regulatory compliance. And then we're going to talk about after action reporting done in conjunction with council. And that will be more of a series that won't be freely available. You'll have to log in to get that information. And we want to do that since we're going to discuss sensitive financial topics. We don't want that available to the public. So we will do a combination of educational series about recovery and all the elements that go into it. And then as a maybe a precursor to that, I will have Jeff and Jen come in and talk about the content of their class. So we made it through in 35 minutes. My hope is that once we end the month of March is to roll these back to half an hour. If necessarily, we can always extend those. But I think because things can change every week, we'll keep the weekly format, but we'll reduce the amount of time that you guys have to spend listening to this. And if there's little changes, we'll address those. If there's big changes, we can always extend that time. So if you guys have no further questions, I'll hang out here for a second. But if not, I wish you guys the best of luck. Have a great weekend, and we'll talk to you next week. And don't miss next week, guys. I promise you, this guy is really, really, really good. So bring your questions, PPE, disinfectant, airflow management, all that good stuff. Bring your questions next week, and we'll talk to you then. Thanks. Have a good weekend.